HPV has come in the cervical cancer field very strongly, and we can dedicate to HPV all the day and probably 3-day course. So in this short lesson, I would like to address some of the points. And so I would speak a little bit about natural history and a little bit on the reason for HPV testing. In the pre-test, we have seen that most of you are oriented to cytology screening, which for sure has been, until now, the best weapon we had against cervical cancer. But I will try to convince you that the data are very strongly indicating that HPV testing should be the first test, the primary screening test for cervical cancer prevention. So, let's go with the slides. What's new in the field? In the last 30 years, the causal association between HPV infection and cervical cancer has been demonstrated, and for this, Harald Zurhausen, which was the German investigator that first pointed out the possibility that HPV is the cause of cervical cancer, received the Nobel Prize in 2008. What we know with the natural history of HPV infection in relation to cervical cancer. This is the natural history of cervical HPV infection. In fact, HPV is a virus that can in mucosal tissue, so you can find the different sites. The most studied site is the cervix, of course, because of the implication with cervical cancer. So the normal cervix enters in contact with HPV, and there is a period where the cervix is infected. As we have seen in the pre-test, almost 80% of women, so cervixes, are coming in contact with the virus. After a period of infection, most of the infection clear and the cervix turn normal. Some infections are persistent, and persistent infection can lead to the formation of precancer lesion. Some precancer lesion can regress to normal, some stay all the life, and some progress to cancer. This is the natural history of cervical cancer, and we use this natural history because we know very well how cancer develops to develop strategies to prevent cancer. So until now, when there is the precursor, we can detect and eliminate the precursor lesion to avoid cancer. But now that we know this part of the story, we have a vaccination that prevents infection of the cervix, and the identification of the population which is at risk to develop the precursor lesion, which is the population that is persistently infected with HPV. So in our weapons, in our armamentarium against cervical cancer, we have the usual strategy that is pap smear screening to detect precursor lesion, but we have two additional strategies, vaccination and HPV testing, to prevent infection, the vaccination, and HPV testing to detect persistent infections, HPV infection. Okay, what are papillomaviruses? Papillomavirus is known from decades. However, only in the recent years, we have recognized the wide diffusion and the benign meaning of HPV infection. HPV was linked historically to warts, to condyloma, and so we have in our mind, we link papillomavirus to condyloma. Now, this was an old story. Now we have to update our story, and we will find, I will show you, that HPV is really very common. It is not a disease. It's a germ, it's a virus that lives with our bodies in our mucosa, and sometimes can give rise to warts, some type of HPV, and sometimes can give rise to precursor lesion, and so it, in this way is linked to cancer. Papillomavirus. Papillomaviruses are species-specific viruses. They are very common and are present in almost all species of mammalian birds. So every living has its own papillomaviruses. More than 100 HPV types have been discovered in humans. HPV, human papillomavirus, infect the skin and the mucous membranes where they can cause typical benign proliferation as warts and papilloma. HPV infection can cause, in some instances, microproliferation not visible with the naked eye. HPV tend to persist for a long period of time, often as a latent infection, because it's not easily recognized by the immune system. And some HPV are associated lesion can evolve to malignant neoplasia. How gets HPV into cells? HPV lives outside the body. They use our surface to live and to reproduce, but they do not enter the bloodstream, or they do not enter in contact with the body. This is very important. This is the reason why they stay a long time and they are often unrecognized by the immune system. The virus typically comes from the external surface, and we know that in the skin the surface is made by dying cells. They are not very alive. The cells that are reproducing are these in the basement membrane. So to infect the cells, it is required a fracture in the epithelium, so the virus can infect the reproducing cell. As soon as the virus enters the cell, disappear, and reappear at the surface when the cell is dying. Okay. And so all the life of the virus is within the epithelium and never comes inside, and the mature virus is only found on the external surface. Okay, which is the natural history. 80–90% of young women acquire the virus at the beginning of sexual intercourses. This is the story that has been shown for the cervix. Most of them become negative after 6–18 months of transit infection, and only a small part of the women of the cervix are persistently infected with HPV for a longer period of time. In less than 30% of persistently infected women develops a precursor lesion, and the vast majority of precursor lesion clears. Some CN persist, but even the most persistent CN3 will never become cancer. We know that about 30% of CN3 become cancer on the long period of time. So in this way, which is an almost ubiquitous infection, very rarely ends up into cervical cancer. Conversely, the association of HPV infection with cervical cancer offers an unique opportunity for cancer prevention. This is a key message, because generally women and also physicians are scared by the presence of a sexually transmitted virus that can cause cancer. But in our history, we are lucky to know this virus, because through this virus we have more opportunity to prevent cancer. These are some of the studies that evaluated the natural history. This is one of the earliest studies, and was a study done on more than 500 college students, mid-age 19 years, that were followed for 5 years. And 20% of women were positive in the cervix at the beginning of the study. During 2 years follow-up, 40% of women with negative enrollment became positive, and the high-risk type were found more frequently, type 16, 18, 51, and the high-risk types. And if we plot the cumulative incidence of positivity, so we sign as positive every time we find one girl that is positive, you see that in 5 years, almost 80% of women showed a persistent, an infection, a transit infection, but a period of positivity. And this is the data we based on to say that most of the women pass a period of time with the cervix infected by HPV. This is a study from younger women, adolescents, 14, 17. We are followed for a shorter time, but we are very closely followed. And again, the oncogenic HPV were present in the enrollment in 20%, in the last visit in 40%, and at least once in 2 positive samples, almost 80%. So this virus is really very common on the cervix in young women. The only 3 girls who were always negative, they referred not to have had intercourse. Now, what happens of this bulk of infection that occurs in the younger age? HPV detectability rarely persists for more than 2 years, 24 months. This time is very important because it's the time we keep also to treat CIN1 in the older patient. We wait before treatment 24 months to have a persistent lesion. In more than 90% of the cases, HPV becomes undetectable within 24 months. And these are the data. Look at the age of these women, very young. This is a percentage of persistent infection exists 12 and 24 months. And as you see, only 10% of the infection are persistent more than 24 months. So the HPV is coming, but also as it comes, it is cleared. Persistent infection may cause development of invasive cervical cancer in 10 to 15 years. Many known and unknown factors are responsible for cancer development. This is another key factor when we speak about HPV. We say HPV is the cause of cervical cancer, but it is the fuel that drives the system, but the reason why among most of the women that have HPV, only very few develop cervical cancer. We don't know. And so it is very important, the host and some factors that we don't know. HPV is essential, but is not able alone to give cervical cancer. There will be many factors that we don't know. But what we know is that this virus is essential. This opens the field to HPV vaccination. And this is a very important study that we will see maybe more times to be present. And these are 20,000 women with negative cytology at baseline that had HPV tested enrollment, and they were followed up for 10 years, and the end point was the development of precursor lesion, CN2-3. And this shows the patients that were cytology negative, they had negative pap smear, and they were also HPV negative at the beginning, and after 10 years, the rate of CN3 was very low. These are the HPV positive, and these are the 16-18 positive. As you see, these two types of viruses carries the very high risk to develop a CN3 over a period of 10 years. And this is these are 2 graphics, 2 plots that come from one of the most important study we have on the natural history of HPV infection that has been done in Guanacaste in Costa Rica. It was done on 10,000 women that were followed up for almost 10 years. These are all the HPV infection. There are almost 1,000 infection. And you see that with time, most of the infection cleared. This is the arrow cleared. And at 24 months, most of the infection, 80%, are cleared. And with time, some are cleared. Some are persistent, and some, in some instances, develop a CN2 plus lesion. This is all the HPV types. And this is the same figure for HPV-16. And HPV-16 is more able of the others to persist and to give lesion. As you see, the clearance is not as the mean of all HPV, and the development of CN2-3 with time is more pronounced than for all HPV. Because HPV 16 is special, is high oncologic capabilities, and also the capacity to escape immune surveillance better than the others. So HPV persistent infection can cause the development of invasive cancer in 10 to 15 years, but many cofactors are involved in the process of cancer development. It will be very interesting to study the transmission of HPV between male and female. And there are some studies that have investigated this field. There are not many, but few studies address in the longitudinal study the status in sex of couples. And these studies show that the role of the partner is not very important. The important role is on the host. All the story, the interaction between HPV and cervix is based on personal characteristic of the single woman. It's not related mostly to the sexual activity. In this study, for example, less than half of the couples that were infected exhibited the perfect HPV type-specific concordance, and more than 1/3 of couples had complete discordance. In this other study, they did multivariate regression analysis in distribution of HPV in heterosexual couples during time, and reporting a new sex partner or the same sex partner or no sex partner was not significantly associated with the risk of infection reappearance. When the infection is cleared, why come again? It's not always linked to a new partner. This is the clearance in the population, and this is the redetection. If we follow women, we find sometimes that HPV is reappearing, and most of the time is not a new infection, this is an old infection that comes out again. And this is also very important because when you are going, as I will show you in a few minutes, to HPV DNA screening, it is very important that when you have a positive woman, this is not linked to the actual partner, but it is linked to her all their life and of an infection that was acquired in the past. So HPV, this infection is very common and is not a disease. To find with this molecular test an HPV does not mean you are infected. We call microbiologically an infection because the virus is not living in the air, is living in the cell. But it's not a disease. The disease are condyloma that are linked to benign viruses, or CIN2-3, which is not a disease, but is the instrument we use to prevent cancer. So it is very important to understand that HPV infection is not a disease per se. Precancer is a rare event, and cancer is exceptional. So HPV infection is very rarely associated to cancer development, but is necessary for cancer development. And this offers a mean to prevent cancer. Now, my lesson was divided in two parts. One was the natural history of HPV infection, the other was HPV testing. And of course, again, there are 10 years of studies showing the reason to move and the advantage to have HPV DNA testing instead of pap smear. I will mostly show the Italian data because in Italy there was one of the most important studies on HPV testing, randomized study, a population randomized study of pap smear versus HPV testing, and this is the example of other studies. So the strategy of prevention was the historical strategy that has caused a decrease in cervical cancer in places where screening is working, is pap smear as primary screening test, identification of precursor lesion, which is CN3, elimination of CN3 through excision and conservative surgery. And thank you. And the screening aim is to identify this lesion. This is a small CN3 that can be identified, excised, and so a cancer for this lady is prevented. And the effect of screening is seen if you look at the map of the world and you see where cancer is now present is in places where there is no screening. Where in places where there is screening, you see that the cervical cancer is low. And this is the demonstration that screening works. This idea to find CN3 and to excise CN3 is really preventing cancer. And we have the slide before, we have new strategy, old strategy. So HPV testing means testing the population for the causative agent of cancer. Testing is aimed again to identification of precursor lesion and is not aimed to detect an infection. The first data, which is very important, that has been also suggested by the pre-test, is this large study on 130,000 women in India. It was a 4-arms randomized study where there was a control, a group of women that was screened with visual inspection with acetic acid, a group of women with pap smear, and a group of women with HPV testing. And this is the cumulative incidence of stage 2 or higher cervical cancer, so advanced stage during years, and here is the HPV testing arm. We have to say that this is a single test, and we know that pap smear is working, doing screening and rescreening, but with a single test, there was a significant decrease in incidence of stage 2. But most important, there was a decrease in death rate that was 50%, a decrease in 50% in the group with HPV testing in comparison with control, cytology, or VIA. So this proved that one test in life can reduce the mortality for cervical cancer of 50%. Okay, which are the limitations of cytologic screening? This is the introduction of organized screening in England, in UK, and with the start of organized screening, there was a decrease in the incidence to 11 for 100,000. But after the first decrease, then there was an uncompromisable area that was not prevented by cytology. These are Italian data that shows that among women who develop cancer, most of them, 60%, never had a pap smear, but this group, that is 25%, had a pap smear, but at some reason, false negativity or inadequate follow-up, and developed cancer. And the same data are coming from the States or from the Sweden, where the cytologic failure studying people with that develop invasive carcinoma is 30% to 25%. So in every series, we found some cases of cervical cancer in the screened population with cytology. While these are data from some European population study, HPV testing, the group of HPV testing, is protecting against CN3 or more severe lesion, more importantly than cytology. This is, after negative cytological test, the incidence of CN3 plus with time, and this is the incidence of women with negative HPV, and this is the population with negative cytology and negative HPV. As you see, the protection that is obtained by HPV testing is five times more powerful than the cytology. After 1 year, is the same type of lesion that are found after 5 years, only with HPV testing. So, In Italy, there is an organized screening program that is parallel to a spontaneous screening program. The organized screening program developed this study on 100,000 women that had 2 screening rounds. And they published a lot of papers, I see in some of the papers, and I will summarize the result of the study. There were almost 100,000 women divided in 2 arms, conventional cytology of HPV testing, and they were going to 2 screening rounds. 1 screening round takes 3 years, so all the women went in 1 screening round, and after 3 years they went to another screening round. The group of women were divided into groups 25 to 34 and 35 to 60, different age groups. The primary endpoint was the detection of high-grade CIN, CN2, CN3, in the first and the second screening rounds, and also of invasive cervical cancer. So after the first round of screening in women aged 35 to 60, the relative detection of lesion with HPV versus cytology was 2 for CN2, 2 for CN3, and 2.3 for CN2 and 3 together. What does this mean? This means that in the group that was screened by HPV testing was found the double of CN2-3 that are in the pap smear arm. So in other words, the pap smear was negative in 50% of CN2-3. So, question, these CN2-3 that were detected by HPV testing are really important, are clinically relevant, or the test detected some CN2-3 that were going to disappear in the follow-up? So we went to the second round of screening, and in the second round of screening, all in this age group, the relative detection of HPV versus cytology was half. It means that there were in the second round, half of the cases that were in the pap smear arm. So in the HPV group, the CN2-3 were identified earlier than in cytology arm, because in the second part of the study, after 3 years, there were half the disease. So you sum up the number of lesions found in the first 3 years, the second 3 years, you find the same number, but HPV testing was anticipating the diagnosis. So which is the clinical value of this anticipated diagnosis? Of course, you can increase the interval. And in fact, we know that with HPV testing, we can increase the interval from 3 years to 5 years. So, but what is the endpoint on invasive cervical cancer? In the first round, there was the same number of cancer in the HPV test and the pap smear. But in the second round, there was no invasive cervical cancer in the HPV type, in the HPV group, and 7 in the pap smear. What means? This means that the CIN3 that had been detected and treated before, because HPV testing was detecting before the CIN2-3, some of those in the pap smear arm develop cancer. And so in this way, HPV testing is able to protect from cancer better than the pap smear. And for the negative women, offers longer interval between 2 screens. So I say, which are the clinical consequences? Stop the pap smear screening and switch to HPV testing. If you see this data, of course, you think, I want to do HPV, because with HPV testing, the person that is negative can go with a longer time to the second screen, and who is positive contains the CN3 that pap smear is not seeing, is not detecting. So HPV testing has 2 main outputs. The first one is reassuring more than 90% of the negative women negative is really negative, an interval between screening increase, and from the other side offer better protection against cancer. And I can anticipate that this system is also cheaper than the pap smear. Okay, what is the result in the younger women? In the younger women, we know that HPV infection is very frequent. There is same result or different situation. The results are even more striking, as in the round 1 versus round 2, there were 4 times more CN3 adenocarcinoma in situ detected by HPV testing, and 5 times less CN3 and adenocarcinoma in situ in the subsequent round. So the difference were more evident in young women than in older women. However, there were, and for cancer, the same, no cancer in the second round, 2 cancer in the second round of the cytology. Of course, the numbers are lower because cancer at this age is not so frequent as invasive cancer in the older age. However, there are some considerations. The sum of the lesion found in the first and the second round in the HPV testing arm was higher. And this means that there was overdiagnosis and overtreatment of the lesion. So the clinical consequence that the investigator tried was the increment in cervical detection is counterbalanced by the increase in diagnosis and treatment of clinically non-relevant CN2-3. We know that some lesions regress, and probably we have in this population too sensitive method to detection CN2-3, and probably we are going to treat more women that are going to regress. So for this reason, HPV testing is indicated from women 30 or older, 30 or 35 or older. However, the total figures of cancer reduction are still impressive in the 2 rounds. This figure, of course, prompted the Italian group to switch from smear and to HPV testing, and in January 2013, the Ministry of Health recommended the region to switch from pap smear to HPV testing, and in most regions the process has been started. Of course, there is a system that is in place, and so it is difficult to change a good system into a new system, even if this is better. If you see that the sum of the cancer is second round after HPV testing is 9 in the pap smear and 0 in the HPV testing. Of course, this 0 does not mean that all cancer are prevented with HPV testing. This is a study done on 100,000 women. If you put 1 million women, probably you will have also some numbers here, but the protection is very high. And this is so high that recently, in November, has been published the results of 4 population-based study done in Europe. And this is the cumulative, the red line is the cumulative incidence of cancer in pap smear screen arm, and this is in HPV testing. And in this graph, you see the women that had a negative test at entry, so we exclude the women that had cancer at time of screening. The protection that is gained by HPV testing is really very high, and at 5 years is below 2 per 100,000. In Europe, the mean is between 8 and 10 per 100,000. So the protection that is given by HPV testing is very important and is confirmed in 4 studies. So it's not only the Italian study, but there are some other studies. So, which is the use of the test? HPV test has a high negative predictive value. And this is very important to know. The negative HPV, the HPV testing that is negative, predicts negativity very, very well. And we will use that in the screening, but also in management of patients with abnormal screening test. HPV test is suited to reassure the negative individuals and to increase screening interval between 2 subsequent screens. At any age, negative test is reassuring. And this also is very important. The negative women are set far from the medical intervention. And this is, again, very important. And this is, again, the slide that I showed before, showing that after a negative pap smear, this is the incidence of CN3 and more severe lesion. This is the incidence after a negative HPV test. And this is the negativity after cytology and HPV negative. When you do co-testing, as you see, you gain a little bit, but this gain for some people is considered to be low enough to use only HPV testing. And in Italy, we recommend to use only HPV testing. So there are no scientific doubt that HPV testing should be used as a primary screening test. However, implementation is still a problem where pap smear screening system is in place. And this is the conventional pap test that changed the epidemiology of cervical cancer. And this is the technology, the wooden spatula. This is the glass, this is the wooden, and this is the technology of the time of Papa Nicolau developed the test. So I think nobody will go on a plane like this today. We have some new technology. However, physician always says, yes, but this plane has only 2 or 3 drivers. It's very easy to manage. A new jet has 1,000 of buttons, and it's very difficult to manage. And I think that physicians should learn how to manage HPV testing, which is a new technique. I thank you for your attention.